We need more trials on daratumumab, but we would love to hear Dr. Putrino's thoughts on the Norwegian pilot study in ME/CFS patients.
Yeah, so I was fortunate enough to be in the audience when the results of the daratumumab trial were first presented in Berlin. And I think that this is a classic example of how we need to understand all of these disease states a little bit better in order to conduct clinical trials that have the best chance of being successful. I think it was that trial was a really good example of generating pilot evidence that we can use specific biomarkers to identify responders and non-responders, and then move into a larger clinical trial. So specifically, in the case of daratumumab, which is a B-cell therapy, if individuals had a natural killer cell count that was too low, they did not respond to the therapy, or in fact, they may have experienced slight worsening of symptoms while they were on the therapy. Whereas people who had higher levels of natural killer cell counts tended to respond and recover quite well on the therapy. I know that the team that is running those trials are now moving into a larger clinical trial where the inclusion criterion is natural killer cell count at a certain level. And I'm really, I'm remaining in touch with that team. I am hoping to get out to Berlin in May of this year to dig in a little bit further and see how things are going. And I 100% agree that we need more trials of daratumumab, and understanding the inclusion criteria and being quite selective about who we let in.
Next question. After influenza A recovery, how long should a person wait to get a COVID vaccine?
So we don't necessarily have clear data on how soon after an influenza A infection it is safe to get, it is safe to get other vaccinations. Generally speaking, we want people to be asymptomatic from their previous infection before they go on to cause an immune reaction by getting another a vaccination. So as a general rule, even though for this particular instance we don't have clear data telling you what to do perfectly, as a general rule, when you're no longer symptomatic from your infection, that would be a good time to assume that it is safe to go off and get a vaccination.
Which blood test do you need before rapamycin?
So in our clinical trial of low-dose rapamycin for long COVID, there are a few things that we are tracking. The first at baseline is we want to look at cholesterol balance, specifically looking at LDL, because rapamycin at low doses long-term can raise LDL cholesterol, and we want to make sure that people are not experiencing extremely high levels of LDL cholesterol, because that can cause all sorts of obviously serious health sequelae like heart attack and stroke, etc., as well as worsening some of your symptoms with endothelial dysfunction and endothelial inflammation. So we track LDL cholesterol. We look at kidney function and liver function. mTOR inhibitors can specifically put a little bit of pressure on the liver. So and the mechanism of action by which rapamycin works is by inhibition of a pathway called mTOR. And so we want to make sure that kidney and liver function are within normal limits and fine. And then the final thing that we test in this particular clinical trial is basically your blood levels of rapamycin. We tend to test for blood levels of rapamycin toward the end of a dose. So we use a weekly dose. So let's say you take the dose on a Monday. we will test for rapamycin levels, on the Friday after you take that dose. The reason we do that is because at high doses, rapamycin is an immunosuppressive drug, and we do not want immunosuppression to occur. At low doses, rapamycin supports natural killer cell function, improves T cell function, and reduces a little bit of extraneous inflammation. However, what we don't want is for rapamycin levels in the blood to build up slowly over time until it gets to an immunosuppressive dose. And that's why in the clinical trial, we're measuring rapamycin levels. Rapamune levels in the blood is the blood test that we use with LabCorp, that allow us to understand, is your body breaking down the rapamycin so there's no risk of your levels building up. In the first month, so we test everything at baseline, then we test everything after a month, and then we tend to, every 2 months, check in on all of those factors.
Is metformin now standard care for a positive COVID test in adults?
I wouldn't say it is standard of care. I would say that there is reasonable clinical trial evidence to suggest that metformin can lower the risk of long COVID in people who take it when they are sick with acute COVID. However, I would not jump out and say everyone should load up on metformin when they get acute COVID. It can have, first of all, it's a drug, so it interacts with other drugs. So you need to be talking to your doctor about the other drugs that you're taking. It can also just have very serious effects on blood sugar levels and just gastrointestinal function. A lot of, for instance, from experiences from our clinic that patients have shared from our clinic, metformin can be hard to tolerate and can cause a lot of GI disturbances. And, if somebody is already sick with COVID and now they're getting a lot of diarrhea and fluid loss, that can actually cause, worsening of symptoms if you're someone who's already sick with long COVID, ME/CFS, chronic tick and vector-borne illness, and you already have POTS. So you're already battling a little bit of a fluid balance issue. Adding in GI disturbance to that can really make you feel quite unwell. So I would say that there is evidence to suggest that metformin might be a good medication to take if you're acutely ill with COVID, so long as you don't have drug interactions, so long as you're not someone who finds it very difficult to tolerate. I don't think it is worth pushing through severe GI symptoms or even mild GI symptoms, if I'm being honest, for the purported effect. So it's definitely something to discuss thoughtfully with your doctor.
Someone asked, lumbarokinase, how long, which quantity?
So we're not going to necessarily be prescriptive on these AMAs, but what I will say is we are running a clinical trial right now on lumbarokinase to try and understand adequate and optimal dosage for fibrin breakdown. Anyone who wants to be a part of that lumbarokinase clinical trial, we are actually in the process of decentralizing it so that people in the United States can participate from anywhere. But what I will say is right now, the reason we're running the trial as an open label trial is so that we can study the effect that it has on symptoms and also on blood coagulability, so that we can better understand exactly this question, because to date, we don't have solid answers for which dosage and how long. We really just have self-report data from patients telling us that they feel better on lumbarokinase or nattokinase in a subset of patients. And we also have some early molecular data about lumbarokinase as a substance where the studies have shown that it does break down fibrin as advertised. It does improve vascular health and function in healthy controls and in animal models. So we are really trying to do the work right now. And if you're interested in being a part of this trial and you're in the United States, you can send us an email at coreresearch@mountsinai.org.
Yeah. I saw that the bezisterim trial was extended about 6 months. Are there any infos about it already?
No, it is a double-blind, placebo-controlled clinical trial. We are in the midst of recruiting for it right now. I think it is a really cool trial. I think it's a really cool drug, but it is a very involved clinical trial. So I think that that's why it has been extended by 6 months, just because everyone who's being enrolled into it is being enrolled very carefully and very deliberately, and the trial process itself is very involved. So we have actually our first couple of patients joining the trial from the core in the next couple of weeks, and we are really excited to push this science forward. But it is double-blind and placebo-controlled, so we don't have any early feasibility data on our end.
Okay.
Plus,
thank you.
Disembodied voice.
Is there any convincing data for trying nicotine patches in ME/CFS? Any guidance around dosing?
There is no convincing published data on the use of nicotine. I do know that people do experience benefit from nicotine patches. Some people have self-reported benefit, and the sort of the sort of purported mechanism, even though no one has done the mechanistic work on this in disease states like long COVID and ME/CFS, is that the sort of cholinergic effects, so the pathway that nicotine works on, the drug nicotine works on, can stimulate the vagus nerve and can help with sort of systemic inflammation and other things. However, one thing that I will say with drugs like nicotine and drugs like caffeine is that we all have, and also things like THC and cannabinoid drugs, we all have different types of receptors to these drugs. You don't just have one type of nicotine receptor. There's a half dozen types of nicotine receptors. And we all personally have different clusters of these different types of nicotine receptors. And so people can have wildly different reactions to trialing nicotine in their system. And so I would say really approach this with caution, because first of all, it's a drug and it's addictive. But secondly, the mechanisms have really not been sort of separated out just yet. So we are still learning about why nicotine may help some people, but it is definitely only a subset of people, and we need more information on that.
For the LC arm of VYD2311, is there a lab you've developed for inclusion?
This is a topic of hot debate right now between the Invivid team and the SPEAR study group of what should be the sort of metric of presence of spike protein or presence of antigen that may or may not mediate inclusion. And I would say it is the final detail that is being discussed at the moment. And right now we don't have a clear answer. One of the things that I would really sort of point everyone toward watching is Michael Peluso's team is about to start a clinical trial or a research study by the name of VIPER. I didn't make up the acronym, so don't come for me. But that is a research study that is looking to optimize some of the sort of metrics that we and assays that we already have for presence of persistent antigen and put them head to head with one another to better understand them. I think there's crucially important work that should have been supported by the government probably 4 or 5 years ago. And it's finally happening now thanks to, folks like the Polybio Research Foundation. And I would say watch that space. It's really important. But we are going to, continue with progress on the VYD2311 trial in parallel.
Awesome. Someone asked, I think again, this might emerge in more clarity with our clinical trial, but someone asked, how long do you need to take low-dose rapamycin to see improvement?
Yeah, all I can give you is anecdote right now. And, in anecdote from what people who have tried rapamycin talk about, it's usually it's usually a 4 to 6 week undertaking to sort of understand if this is something that is really moving the needle for you. And it can be longer or shorter depending on how people slowly ramp up to their effective dose. And so, some people have to start extraordinarily low and slow, just like LDN, and slowly build themselves up. LDN being low-dose naltrexone, whereas others can move immediately to a dose that the doctor believes is effective for them, and so maybe they may experience benefits more quickly. But it is a really powerful medication, and a lot of people do need to start quite slowly. So, but in general, from sort of like aggregating a lot of the conversations we've had with people out in the wild who are sort of like trying these things, you're feeling something by 4 to 6 weeks on average.
Someone says, what's the best way to get in touch with your clinic? I've been trying to make a follow-up appointment.
I know that the clinic is slammed right now, but core@mountsinai.org via email is probably the best way to get in touch.
Would people in Canada be able to participate? I assume that's in the decentralized trial. The answer is no, right?
Yeah, unfortunately, most of our decentralized trial structures don't allow us to cross country borders, and they don't allow us even to cross waterways. So we need contiguous US states as well as US states, unfortunately. These are due to sort of like licensing issues that unfortunately don't cross borders.
Does birth control pill use impact long COVID endothelial issues?
Birth control use can always have endothelial effects and effects on the endothelium. I mean, there's a lot of factors that come into this, of course. There are different forms of birth control. Certainly, birth control that utilizes progesterone, we always sort of indicate to people who are on birth control who are attending our clinic, we want to understand what is happening with their hormones before we make recommendations about what they're taking for their birth control, because we know, Akiko and I have published some work, and others in the field have also published work showing hormonal dysregulation in folks with long COVID and most likely other infection-associated chronic conditions and illnesses. We also have some work that we hope to be publishing this year showing how hormones like estrogen and progesterone and luteinizing hormone can actually worsen or lessen symptoms based on their relative magnitudes. And so one of the things that we try to recommend and we want to do more work on is how to advise on this in a data-driven fashion based on your own personal data. So how do we better understand what is happening in your cycle so that we can say actually taking progesterone right now maybe isn't a good idea for your endothelium or for your post-exertional malaise symptoms, or taking something like bioidentical progesterone for your POTS might be a very, very good idea, because it will help you sort of retain fluid in your circulatory system and feel a little better without needing to take down 6 liters of water and 5 grams of salt every day. So so it really does depend a little bit, and it's a little variable based on your own hormonal cycling.
Next question, can Xofluza help long COVID?
So Xofluza is an antiviral that appears, according to the data right now, to be a very good match for this year's influenza A virus. Can it help long COVID? I would say no one has done the research necessarily, but I would say no. It is really sort of targeted toward in the influenza virus, and so, different virus, different structure, different mechanism of action for stopping that virus. So it's unlikely that it can have an effect on SARS-CoV-2 as well. But, again, there's no data either way to sort of support it. It's just not the first thing to reach for with acute SARS-CoV-2.
All right, next question. Is there a promising approach emerging in research for treating sick children? What treatment options might be most suitable?
The core does not yet see pediatric cases, just because we do firmly believe that that children are not just small adults; they have their own physiology, and it's important to really delve in deeply to understand that. So, although through partnership with one of our sister centers, which is the Charles Lazarus Children's Abilities Center, we do provide kids with POTS rehabilitation and rehabilitation of autonomic disorders, thanks to mentorship from professionals at the core. We don't medically manage kids with long COVID. Maybe it might be nice to do a version of this AMA for pediatrics, if people in the audience would like that, where we invite Danilo Bonsenso from Rome to come on and answer some questions. I think he'd be delighted to do so. Not to put him on the spot, but he's a very nice man and he's very generous with his time. So I think that he would be happy to do that. And in my opinion, he's done some of the most large-scale, large N research on pediatric long COVID, and so then therefore he has a lot of data-driven answers on medication dosages and medication approaches for treating kids with long COVID, and how that deviates from adults with long COVID.
What do you recommend for inflammation?
Oh boy, well, it depends. We're getting a lot of "it depends" questions today. Really, when we see inflammation, we want to try and understand what is driving the inflammation. Are you experiencing inflammation because of autoimmunity? Are you experiencing inflammation because of vagus nerve dysfunction? Are you experiencing inflammation because you have reactivated pathogens and persistent SARS-CoV-2 infection? So what we try to do, and our approach at the core that we recommend, is not just to stop at you have inflammation, but to try to dig deeper. You have inflammation plus you have an abnormal tilt table test. So we're going to get you set up with autonomic rehabilitation, vagus nerve stimulation, perhaps drugs, that dampen down sympathetic activity and upregulate parasympathetic activity to reduce centrally mediated inflammation, versus other approaches, such as some of the work that we've published with Dr. Pridgen, for reactivated pathogens if we think that the inflammation is being caused by a chronic EBV or HHV6 reactivation. So really asking the question of not just do you have inflammation, but why do you have it, I think is crucially important.
All right. Do you have results with your clinical trial using an oxygen concentrator in ME/CFS patients? With what other, I guess, conditions could it help?
Yeah, so right now we only have open label data for the oxygen concentrator, and we do have a mix of patients with EDS, Ehlers-Danlos syndrome, ME/CFS, and long COVID who have been using this, and also chronic tick and vector-borne illness. So far, in general, most people, I would say like 80 to 85% of people report that they do get a significant boost from the oxygen therapy using a concentrator under clinical supervision, of course. And I do think that the physiology supports the use, and what I mean by that is taking together the findings of both Rob Wust and David Sistrom, where they have shown, respectively, Rob has shown that we switch over to anaerobic energy production strategies in ME/CFS and long COVID much earlier than healthy controls and deconditioned healthy controls. So he has shown that it seems like a lot of the energetic problems come from a lack of easily bioavailable oxygen. And then similarly, David Systrom's team has shown that folks with long COVID and ME/CFS who experience PEM have reduced oxygen extraction in their blood, again indicating that the blood is circulating around, but the body is not taking the oxygen from it. Both of these things point to an idea that if you make more oxygen more available, you may not be fixing a problem, but you may increase the chances that your body can take some of that oxygen and use it for energy, use it for ATP production in an aerobic fashion, as opposed to an anaerobic fashion, which causes lactic acid buildup, waste product buildup, and then subsequent crashes and feeling unwell for many days. So the physiology points us toward the idea that it's a good idea. The early sort of open label trials have indicated that it seems to help folks, and that folks keep coming back for it. We have repeated measures data to suggest that it's the effect isn't really falling off. People aren't saying maybe there was a little placebo effect bump, and then they sort of went back to it not really helping. They ask for the therapy. We do need proper randomized controlled trials of this, however, and dosage parameters, and for that we need funding. So it's something that we're writing grants for and looking into.
In the PRIGIN-CAR protocol, do you think the reported relief of neuropathy is the Valtrex targeting B cells potentially infected with EBV?
I'm sorry, could you repeat that one?
Yes. In the PRIGIN-CAR protocol, do you think the reported relief of neuropathy is the Valtrex targeting B cells potentially infected with EBV?
I think it is a reasonable theory. I also think that a reasonable theory is if there is EBV infecting the tissue around nerve cells, and that is causing inflammation, that could also cause neuropathic pain. So we really, the point of the SHIELD trial, which we will be starting in Q1 of this year, which is a placebo-controlled RCT of the PRIGIN protocol, where we will also be taking biospecimens. This is what we hope to answer in that trial.
Lovely. And Treg therapy sounds so promising for CFS long COVID. Any predictions around this? I heard a researcher suggest 5 years until patients can access.
Yeah, I think any immunotherapies that are targeting T cells and improving T cell function. I absolutely think that these are things that should be trialed in folks with long COVID. I hope that 5-year mark is. I hope that 5-year mark is a pathway toward sort of indications as opposed to any level of mainstream access. And the other thing that I hope is that given the current administration's interest in infection-associated chronic conditions and illnesses, they may make some of the compassionate use paradigms for some of these drugs via the FDA more easy to access and less cumbersome on doctors, so that patients who have a right to use these things and a right to the sort of personal autonomy of trying out therapies that have a good faith basis for helping mechanistically can more easily access these drugs.
All right. Wondering if you have theories, big question, on why patients with hEDS, MCAS, POTS tend to have lingering and more serious recovery time from even run-of-the-mill viral illnesses.
Oh, I've got nothing but theories about this. I think that where to start here? I mean, hEDS is such a big topic. I do think that a lot of folks get diagnosed with hEDS because they are hypermobile, and not necessarily because they meet all of the inclusion criteria for hEDS. So for instance, Dr. Amy Kantorovich at Mount Sinai is an hEDS expert that we work with very, very closely. And to be diagnosed with hEDS versus a hypermobility spectrum disorder, Dr. Kantorovich really goes deep. There needs to be an echocardiogram. There needs to be an EKG. She measures heart chamber size. She does genetic testing and genetic counseling. She gets a sort of a family tree, rundown of the patient's tests for POTS. Long sort of questionnaire. She uses the sort of Lake Louise criteria for this. And so it is actually quite challenging to get an hEDS diagnosis from Dr. Kantorovich, because it's a very rigorous diagnostic process. Whereas folks who have hypermobility spectrum disorders or hypermobility spectrum symptoms, I think that there is actually a really, we're starting to learn there is a really credible link between persistent pathogens and pathogenic infections and hypermobility. If you look at some of the work that Mickey Tal from MIT published just late last year, showing that Borrelia in animals will, in mice models, will burrow into collagen and burrow into ligaments and create hypermobility symptoms in mice. And you see the way that many folks with long COVID and ME/CFS have reported the development of hypermobility spectrum symptoms. I think that we are dealing with situations where you can have conditions like hEDS, where there's a genetic component and you're experiencing hypermobility alongside another sort of cluster of different clinical manifestations and presentations. But on the other side of things, there is just joint hypermobility that could be infection related, could be histamine related, and could be chronic inflammation related, that may of course make you susceptible to lingering illness. Now, all of that said, we also need to acknowledge the fact that folks with hEDS also do, the longer they have had hEDS, most hEDS specialists will tell you they do experience some immune senescence, meaning that their immune system becomes less effective, and you can often see a white cell count drop in folks with hEDS when they've been sick for a number of years. And that can also lead to a prolonged recovery from illness and being hit extra hard by an illness. And of course, it may also make you more susceptible to infection-associated causes of joint hypermobility. So I've said this a few times now, in the world, there are lumpers and there are splitters. There are people who say, let's lump everything together. And there are people who say, let's sort of try and tease apart the differences between these similar but distinct groups of sick people. And I think with hypermobility, once again, with joint hypermobility, we're really trying to split. We're really trying to understand who may have more genetically linked hypermobility spectrum issues, who may have more infection-associated, inflammation-associated, autoimmune-associated. So I'm sorry for the long, complicated answer, but like I said, I got theories on this one, and I think we need more work to fully tease these things apart.
All right. The next person is asking, have you read the recent research from Columbia differentiating long COVID from post-vaccine syndrome? Have you seen differences in your clinic or research?
Yeah, I have seen that work, and I think it actually fits in quite nicely with the work that Akiko's team and our team and Harlan Krumholz's team pre-printed probably about 2 years ago. We have been unable to publish in a peer-reviewed journal despite using identical methodologies to some of the long COVID stuff that we've published in some of the most prestigious journals in the world. But we do see, briefly speaking on this, what we do tend to see is more of a relationship between spike protein and persistent antigen in folks with post-COVID vaccine syndromes than necessarily that we do in folks with long COVID. So it's not that folks with long COVID don't have persistent antigen, but what we showed in our study was that, in the post-COVID vaccine syndrome, it was up to 4 times more in the sera of people with this post-COVID vaccine syndrome. So I do think that there are differences. Clinically speaking, I think that folks with post-COVID vaccination syndrome, what comes from our clinic is that they tend to be more difficult to treat. And I think that comes from the fact that there's, with long COVID, ME/CFS, other infection-associated chronic conditions, there's so many different drivers, and we have different tools to treat the different drivers. Whereas with post-COVID vaccination syndrome, there is, there's one main driver, which is the spike protein, and we have less effective strategies to treat this, which is why, the SHIELD study, the spike study team, there's too many acronyms in my life, working with Invivyd, made the decision to include both long COVID and post-COVID vaccination syndrome patients in the clinical trial, because we do acknowledge the importance of creating therapies for these folks who may be, suffering symptoms of a spikeopathy.
Pediatrics would be helpful to hear from. Good idea. We're getting encouraging comments on that. Read Dr. Putrino's study where purified IgG was transferred from LC patients to mice. Are you hoping to run more studies like this to look at whether specific IgG subclasses are responsible for symptoms?
Absolutely. We're doing a couple of things on this front. We are absolutely trying to put our heads down with different companies and plan out how to do an FcRn inhibitor trial that would be effective and successful. because I really believe that folks, because in that passive transfer trial, not everybody's IgG stimulated symptoms in the animal models. It was a subset of people with COVID, which I think means that there is a subset of people with COVID who are long COVID, who are experiencing, this increase in autoantibody proliferation and production. So I do think that there is a subset of folks who will respond to FcRn inhibitors. I'll also point out that, the VYVGART trial that occurred, the Sick Times ran an article just talking about the fact that there were some really super responders in that trial. What we're doing is we're actually trying to round up anyone who was in that trial who knows that they were in the active treatment arm, who had a positive response to VYVGART, and we're bringing them in to repeat the passive transfer trial with their IgG. Our theory is that purified IgG that comes from folks who are responders to an FcRn inhibitor are going to be much, much more likely to make our animal models symptomatic than just a random sampling of people with long COVID. So that's what we're doing right now. And we've already had about, I think, 10 lovely people who were in that VYVGART trial who responded strongly, who have volunteered. And we've also successfully decentralized participation in that trial as well. So if you're anywhere in the United States, you no longer need to travel to us to give your blood. We can get your blood at point of care and mail it out to Akiko Iwasaki's team at Yale.
Yay. Okay. What is the link between SIBO and long COVID? I have the feeling I could have already SIBO and mild dysautonomia when I developed long COVID. I just got diagnosed with SIBO. Thanks.
Yeah. So, I mean, I think some of the earliest work that was published on viral persistence in the gut around long COVID not just showed that viral persistence in the colon and the ileum, which are two sort of like the upper part and the lower part of your gut, was very common. But in addition to the persistence, we saw gut dysbiosis. So we saw that some of the bacteria that usually are sort of like just living in your gut, helping your body to break down food, doing a good job, being good allies, being good bacterial allies to us, get knocked out of balance, and we start to see proliferation of bacteria in a way that can either just be dysbiotic, so you've got too many bad bacteria, or you've got too few good bacteria, or can occur in just an overgrowth. So meaning that you start to get SIBO, small intestinal bacterial overgrowth. So you start to experience a rapid proliferation of bacteria faster than it should be happening into the small intestine. So we definitely know it co-occurs. We think it is just related to the destabilizing effect of persistent antigen in the gut. And we also think that, as a result of this destabilizing presence of persistent antigen in the gut, the small intestine, the stomach perhaps, you also, you can have problems beyond just SIBO, so SIBO is one thing that we do see frequently occurring, and is very important to address. We do see gut dysbiosis, so just the imbalance. We see leaky gut, and I would refer everyone to some brilliant work by Lyle Yonker at Harvard, who showed that leaky gut in kids after long COVID could be treated with lorazepam, and not only did it improve symptoms. Lorazepam is a specific drug that reduces leaky gut, so it makes the gut less permeable. And what Lales data showed is not only did kids improve if they had leaky gut, not symptomatically, but she was also able to show less circulating spike protein in their plasma after taking the lorazepam. So definitely, I think that all of these gut issues, whether we're talking new onset IBS, new onset leaky gut, new onset SIBO, and dysbiosis, I think it all comes back down to persistent antigen causing dysbiosis and dysfunction of the bacteria naturally in your gut.
All right. Is there any information on the research of BC007?
Not to my knowledge. I am sure, I have no doubt. I mean, it seems like such a valuable data set. I have no doubt that somebody is looking at it. But I do not have, my head is full of amazing noises today. I do not have specific data on the BC007 clinical trial. I'm echoing.
What research are you currently most excited about, and what therapies look most promising from your perspective?
Oh God, I'm very excited about getting started with both the SHIELD trial, which is the Putrino protocol, and the VYD2311 clinical trial. I am so bullish on monoclonals, not just because I think that they have the potential to help a large number of people with long COVID, but also because I think that they have the potential, if we use them correctly and we use them for post-exposure prophylaxis, I think they have potential to stop future long COVID cases. I've often said the only way to not get long COVID is to not get COVID. Now we have another option. The only, a good way to not get long COVID is to take a post-exposure prophylaxis medication that stops you from being appreciably infected by the virus afterwards. And so I'm very, very excited that not just Invivyd, but other companies as well are starting to produce post-exposure prophylaxis drugs for SARS-CoV-2, because they understand that SARS-CoV-2 is a different virus. It's not flu A, it's not flu B. It's its own thing, and it is very, very damaging, and we need to be limiting the amount of times that people get infected with this virus. So VYD2311 is something that is getting me excited for sure, as is the Putrino protocol, just because we've seen so many good results on it. The other study that I'm really excited about, we will be posting results about this in the next month or so, is we finally completed our clinical trial of a device using microtesla magnetic therapy. It was a placebo-controlled trial, and we saw significant responses. We saw significant improvement in cognition in people who had long COVID who received the active treatment versus the placebo treatment. So the active treatment did outperform the placebo treatment. And I think I've said this before, we find cognitive symptoms are some of the hardest to treat. And so anything that successfully treats cognitive symptoms immediately gets me very, very excited, because I know not only are they hard to treat on the clinical side, I know for the patient community, they're some of the most troubling and panic-inducing symptoms, because of just the inherent fear that we all have of losing cognition rapidly. So I'm really excited to be sharing those results soon.
Can one say that early rest and good pacing still offer a chance for recovery and healing? Does the longer and more chronic the condition, the more difficult the healing, or is it not that simple?
No, I mean, I do think that we do have emerging data to suggest. There have been a few publications. These are really hard things to prove, but we do have a few publications out there in the world that indicate that people who pushed through symptoms and aggressively attempted to sort of like return to their normal life were more likely to experience prolonged symptoms. And we also, although this doesn't quite answer the question, we also have data to suggest that folks who have been sick for more than 9 months are much more likely to, much less likely to experience spontaneous remission. Now, it's unclear the role, specifically the causative role, that rest, pacing, and a slow return to pre-infection activities might play in preventing you from turning into someone who does not experience spontaneous remission and goes on to experience a chronic disease state. We don't have those causative data, but we do have data suggesting that we do have data that are suggestive enough that my general advice would absolutely be, if you test positive, rest, pace, hydrate. Don't try to push through. Don't sort of feel the sort of social pressure to return back to work and just continue to play sick. Really wait until you're asymptomatic and follow American Heart Association guidelines of waiting until you're 2 weeks beyond your COVID symptoms to think about resuming exercise. So I would say we can't make that causative link, but we do know that that rest seems to help.
All right. What was the criteria you mentioned that Dr. Kantorovich uses to evaluate hEDS? It sounded like the Louise criteria.
Yeah, Lake Louise, beautiful lake in Canada, Banff, Canada. Go if you can. That's you'll find that a lot of criterion that have been developed are named after really beautiful locations, because this is where all of these like cardiologists or whoever are making the criteria like to go for their conferences, and then they make the criteria there. So they were probably making these criteria whilst having a really nice view of Lake Louise.
One thing I haven't seen in the research yet is anyone looking at the role of IgA in inflammation mediation. Can you speak to that?
Yeah, there are some studies about this, looking into IgA. Most of the studies you'll see are about IgG, but there are some studies out there looking at sort of IgA-mediated inflammation and IgE-mediated inflammation. There was just a study that came out about that. That it is fewer and farther in between, and I do agree that more research would be valuable in trying to understand the sort of like the mediation of different immunoglobulins and the effects that might have systemically.
12 weeks into IMC2 now, and I can see the changes on my smartwatch, so hopeful this might be the solution.
Oh, yay. That's good news.
Yeah. Any thoughts on why methadone works so well for a certain cohort of LC patients?
I think that reading David Systrom's work is really important here, because he has beautiful physiologic data showing that with methadone, in his study that he's currently conducting, he uses a combination of LDN and methadone. What he shows is with invasive CPET, so he's doing really, really beautiful physiology work, and he's published on this. You can actually see that methadone reduces preload failure in the heart. So whilst giving someone a dose of methadone, he's improving heart function. And this is in a cohort of people with long COVID and ME/CFS who have PEM. That was the inclusion criterion for the work that Systrom is doing. So physiologically, what methadone is doing is upregulating parasympathetic nervous system activity just as a drug. But in folks with long COVID and ME/CFS, what Sistrum is showing is that it is improving heart function in such a way that you're able to get more blood around to all of your organs, your brain, your and you know, all of your tissue effectively. So it is, again, it's making, the way I simplistically think about it is, if we think about PEM as being a lack of bioavailable fuel to make energy, it's making fuel more bioavailable to the system and to the body.
All right. It's 8:45. We have 3 questions left.
Let's get through the 3. Yeah.
All right. I get significantly worse when taking SSRI. However, it reverses directly after discontinuing the medication. Have you heard of that in other patients and have ideas why that is the case?
You know, I think that we still don't have, you know, I know that the group in Pitt published that amazing paper where they were able to show that sort of gut changes and gut persistence of SARS-CoV-2 sort of correlated with low plasma serotonin. But I still don't think that, because on the back of that paper, the answer is as simple as give the body serotonin, and certainly not give the body serotonin in the form of an SSRI that basically is kind of a hammer that is just like ostensibly necessary, potentially flooding your brain with serotonin. And so, and I would also point out that plasma serotonin levels being low is not the same as brain serotonin levels being low. So the way that many SSRIs work is they will increase availability of serotonin in the brain. And if your brain doesn't need that, it could very well cause, you know, nervous system dysfunction and changes in nervous system function. So we don't fully understand it yet, but I do think that linkages between serotonin, low plasma serotonin, and long COVID are more complicated than the initial publications might indicate.
All right. Do you know why the Sivapibart trial failed?
Well, I mean, I wish I knew. So no, I don't know. And I think that, you know, the reason that we take a lot of time to do really deep physiologic measures on every patient who goes through a trial with us is so that we can better understand why there are non-responders and responders. Because I continue to sort of sing this tune that if you're going to do a clinical trial in folks with long COVID or ME/CFS, you need to either know exactly pre-hoc, before you start the trial, exactly how you're going to characterize the people that you let in based on the mechanism of action that you think your drug will have, or you better be ready to do a deep dive on everyone's physiology and try to figure out post hoc, after the trial, why people responded and why people didn't.
Most interest in vitamin B12 relates to low serum levels. However, my B12 levels are high, over 1,000. Have you seen this in any other patients?
Yes, we do often see high levels of B12 in folks. And, you know, sometimes, I mean, start with the obvious first. Sometimes people are just supplementing heavily, and so B12 levels are high. Other times, B12 is not bioavailable to the body as a result of physiology changes. And so a supplementation approach that makes the B12 bioavailable then allows the B12 to be used by cells and tissues, and that can lead to you know, normalizing of the B12 levels and improvements in energy and neural function, etc. And so those are the two reasons that we frequently see high B12 levels. And the latter, the inability to process B12, that can be addressed by improving sort of the methylation of supplements that are being taken. That can be improved by tweaking some other physiological factors, such as taking, supplements that make B12 more bioavailable. There are some supplements out there like benfotiamine that have been clinically proven to do that. And that's the sort of balance that should be discussed with people's physicians and functional medicine doctors who really have a deep understanding of this stuff to better understand why those levels might be so high.
We've got one more question. I don't know if you want to answer it.
Okay, one more, and then I gotta run.
Okay. Any thoughts on how to best address endothelial dysfunction without evidence of microclots? Any thoughts on how to best address endothelial dysfunction without evidence of microclots?
I would say that in general, for endothelial dysfunction, there's the medication route, of course, working with your physician on use of statins. I know that a lot of folks with long COVID and ME/CFS have benefited from use of statins. There are also supplemental approaches. Supplements like pycnogenol and lycopene, which we talk about in our provider manual, and we cite publications that have shown this, have been shown to help to normalize the reactive hyperemic index of people who have endothelial dysfunction, whether or not microclots are present. So there are supplements out there, and of course there are drugs. The point of statins is to normalize a reactive hyperemic index and heal the endothelium. So those are the two approaches that obviously we talk about in our provider manual, and there's some more references there that could be useful.
We have a lot of thanks in the comments. Thank you all for coming out and for your great questions. I think we are done.
Awesome. Well, have a great weekend, everyone. And yeah, thanks for wonderful questions today. Really appreciate it.
All right. Bye.